Ladies and gentlemen, welcome to the ARCO Forum. Today, the Institute of Politics is very pleased to host this event called Children's Healthcare and the National Agenda, Designing a Plan for the 21st Century. And this event was initiated and planned by a group called Project Health, which is affiliated with the Institute of Politics Student Advisory Committee. And Project Health, we trust you, many of you will know already, is a student community service organization that is unique to say the least. Its people work as volunteers at the Pediatrics Department of the Boston Medical Center, assisting and helping patients and families in need, but in addition to that, engage in examination and discussion of public policy issues and in advocacy to try to bring about change in the public health sector. They are particularly assisted by one of our members of our audience, Bill Harris here. Bill has been a very good friend of the Institute of Politics and a very good friend of this student organization. We're glad to have you with us, Bill. And we're particularly delighted that Senator Kennedy has been able to be with us today from his busy schedule. At the Institute of Politics, he's been an integral part of our work since it was founded 30 years ago as a memorial to his brother, and he has played a role in it ever since, and he's on our senior advisory board where he gives invaluable advice and support in order to make our benefits to the students more available. I didn't see that remark, Senator. It's particularly today, as you know, the Senator is known for his work in healthcare policy and health insurance issues. But in today's climate in Washington, with such bitter partisanship that appears on the surface to stalemate so much potential activity, the Senator has been giving very unusual leadership to reaching across the aisle, and as I think most people know, is responsible for the leadership on the Kennedy-Kassebaum legislation, which was one of the achievements of the last Congress in terms of health care policy. And indeed, timely for our event, just has announced a new joint venture with Senator Orrin Hatch of Utah to take an initiative to bring about health insurance for children in poverty in our country. So we're delighted he can be with us. But it's my particular pleasure to introduce our moderator for this panel, Sheila Burke, the new, not so new now I guess, Executive Dean of the Kennedy School of Government. We're delighted that she's bringing her special leadership talent to the school. Originally, she was educated as a healthcare professional and indeed worked in the field. She's a graduate of the Kennedy School of Government. I hope all Kennedy School students know that here. But she has for many, many years been one of the country's leading experts in healthcare policy, working in the United States Senate on the Senate Finance Committee, first of all, and most recently for a number of years as the Chief of Staff to the Majority Leader of the United States Senate, Senator Robert Dole. Ladies and gentlemen, Sheila Burke.
Thank you very much. It is a great pleasure to be here this evening. We gather, in fact, thanks to the undergraduate students involved in Project Health and the Healthcare Forum, and we owe particular thanks to Sapinda, who I hope is here, for the enormous work that she did in getting our panel together, and we thank you for that. We all remember very well, and I'm sure Senator Kennedy more than any of us, Hubert Humphrey's remarks. It was once said that the moral test of our government is how that government treats those who are in the dawn of life, our children, those in the twilight of life, the elderly, and those who are in the shadows of life, the sick, the needy, and the handicapped. Well, tonight, of that list, our focus is children. It is a pleasure to join with this distinguished panel in talking about an issue of critical importance to all of us. Whether our children should be cared for or not is not the issue for men and women of conscience. The issues that have bedeviled us are the hows, the whos, and the how much. Every recent major piece of healthcare legislation has contained some provision dealing with children, and we have had as many proposals as there are members of Congress in trying to deal with this very difficult issue. We have argued over whether it is a state problem, whether it is a federal problem, or simply a private sector problem. And while we have fiddled, Rome has burned. The number of children who have no health insurance has increased dramatically. Are they being cared for? Yes, in some cases, and in some respects. Is it optimum? No. Is it close to optimum? Absolutely not. Project Health, as Phil indicated, has had as its focus discussing the very issues that we are in fact going to discuss this evening. and our panel is supremely suited to help us sort through these very difficult issues. We also have a tremendous opportunity to hear about a very recent and very newest piece of legislation, which I might note, as Phil did, is in fact bipartisan in its authorship, which is the focus on children. The Hatch-Kennedy Healthcare Insurance and Deficit Reduction Act, those terms are not necessarily inconsistent, will in fact be the remarks that Senator Kennedy will talk about this evening. It promises to be a very lively debate over the role of government, over the role of the private sector, and the very interesting question of user fees, in this case, cigarette taxes. We will this evening first hear from Senator Kennedy, who will talk with us for about 15 minutes, and then from each of our panel members. We will then follow that up with questions from the audience, and I encourage you to be aggressive in your questioning. There are floor mics available to you. We will go until about 7:15. The senator from Massachusetts needs absolutely no introduction to this group, to any of us. He is a longtime supporter of the school. He is critical in the creation and the growth of the Institute of Politics, as Phil has indicated, and his attention and really involvement of issues relating to health care, to labor issues, to Judiciary Committee issues are known to all of us. Much of the major legislation in recent years that have dealt with these issues have had some input from Senator Kennedy. In many cases, it depended on his leadership and his aggressive posture on the floor to get them passed. As someone whose job it was to staff the leader on the other side of the aisle, I never looked forward to seeing Senator Kennedy come to the floor of the United States Senate. But it is with a great deal of pleasure that I welcome him here tonight. Please join me in welcoming him.
Thank you very much. First of all, to thank Sheila Burke for her kind introduction and also for her leadership here in the School of Government and the Institute of Politics. I think Sheila Burke has demonstrated once again that you don't have to be a United States Senator to make a difference. She has been a very key and effective, not just a staffer, but someone who is an intimate part of all of the leadership that Bob Dole provided over very many years in the United States Senate. And while we have some differences on the public policy, I have enormous respect, as every member of that Senate, Democrat or Republican alike, about her constructive attitude and about her commitment to the nation and the workings of the Senate, and also to the principles which she adhered to. So Sheila, I'm grateful for your presentation. To Phil Sharp, and I thank you for all the good work that you do here at the Institute, an effective member of Congress for a number of years, and continues to work with those here at the Institute. I've enjoyed working closely with him, and I commend him for all of his efforts and leadership in the Institute of Politics. I want to just mention those wonderful students who have brought us all here. I know many of you are here tonight, but I do want to recognize Rebecca Oney, and if they'd be good enough just to stand, Mike Mai and Supenda Bajanovic and Rucker Alex, if they would just stand. We thank all of them at the Health Project and all the Institute, and my distinguished colleagues are going to be introduced in just a few moments. I'll try and be less than the time that's allotted because it's most interesting to hear their comments and most important to have the opportunity to respond to the kind of questions that are here. Most people believe that when there's a Hatch-Kennedy bill or a Kennedy-Hatch bill, they say one of the two haven't read it. And, but that's not true about this legislation that is dealing with the children of the country. People ask why. Why now? Why children? The important fact to remember is that 9 out of 10 of those that are being dropped from the private insurance sector are children. So it's an expanding, growing number of vulnerable people in our society that will grow by several million by the year 2000. So it's a factor that is impacting our communities in a very, very important and a direct way, and expanding dramatically in states all across our nation. It is a national problem. Secondly, who are these children and what are their conditions? These are 10 million children. Those parents, 90% of their parents work 40 hours a week, 52 weeks of the year. We have tried to address the issues of the neediest in the Medicaid, and as part of President Clinton's program, they will see an expansion of the focus on some 2 to 3 million of those children who are eligible and are not receiving the Medicaid. Tragically, a great percentage of those, a high percentage of those, are in our own state of Massachusetts. So we find a growing population that are children. We find that these are the sons and daughters of working family, people that are playing by the rules of the game, and the only reason for not providing the health insurance is because of the limitation on their resources. So they are in the bottom of the second rung of the economic ladder. And what is the lot of these children? These are children who have earaches and never get a chance to go to a primary care doctor. These are children who have asthma and never are able to get the kind of attention that they need. These are children that have difficulty in terms of their sight and yet go through year after year of school, frustrated, not knowing why they do not learn, being ridiculed by members of their own class, unable to learn, punished by their parents perhaps because they haven't had an adequate eye test. These are children who say that the emergency room is their primary care doctor. We're paying for coverage of these children, but we're not providing the kind of healthy start that every parent in this country believes should be available to every child in this nation. Secondly, how are we funding this? We're funding it with a cigarette tax. And what is that tax? 43 cents. Why does 43 cents? Because that'll provide the resources to cover effectively with the other provisions the children who are not covered, and provide for a small down payment in the deficit reduction, which Senator Hatch insisted on and which I support. So that will be the arrangements. And how does it work? There are 31 states that are in different periods of developing programs within their states to cover their children. So what we are building upon are the initiatives of the states, And what we are talking about is private sector competition, where the insurance companies are competing in their states for the opportunity of providing, under the state guidance, the nature of the program that will be available to children. So we're building on the states, we're building on the private sector. Those programs will be enforced at the state level, and we're building on programs that are already starting. Why do it with a voucher rather than a tax credit? Tax credits have been tried in the early 1990s. As the GAO report points out, they have not been effective because they don't provide the resources at the time for those individuals to be able to purchase the program, and by and large, the neediest people don't even have the availability of the credit to provide for the coverage of the children. Now, what does 43 cents represent in terms of the sale of cigarettes in this country? Adding a 43 cents tax, when implemented, will put the tax in terms of federal, state, and local taxes at percentage-wise about where it was in the early 1960s. It'll say that the tax that we are providing at the federal, state, and local level is half of what it is in virtually every industrialized nation today. Effectively, what it is saying is that the 33% profit that is available to the tobacco industry for the sale of every pack of cigarettes will be reduced to 17 cents, to about what it is in Europe. And the tobacco industries fight vigorously for market share in Europe. So we believe that it is a reasonable response. But beyond all of this, we think one of the compelling reasons for this particular proposal is that what it will do to the children, the 14-year-old, which is the average age when individuals start up smoking, in terms of halting or slowing down in a dramatic way their addiction to nicotine. That is what is happening. That is where children come in. This isn't a decision that is made on the free market on the basis of information and where we make our own judgments. This is enslaving children at a vulnerable age, 14 years, and making them addicts. They're the ones that are targeted, and all of the studies and the Liggett information indicates that. So we have bipartisan support. Why? Because the issue of children is bipartisan. It isn't a Democratic or a Republican issue. It applies generally nationwide. The greatest numbers of children that aren't covered are in the southern parts of this nation, and we are concerned equally about their interests as we are about the growing number of uncovered children here in our own state of Massachusetts. This is the issue. This is the time. Congress has the opportunity. to pass this legislation. It'll make a major difference in terms of the quality of health for children in this country. It'll make a major difference in terms of discouraging young people from being addicted to cigarettes, and it is time that we had a Republican, Democrat, bipartisan effort to deal with the future of our country, which is our children. Thank you.
By Senate standards, that was the shortest speech on record. Thank you, sir. Our first panelist, Rob Rustuccia, is going to talk with us a little bit about his organization. He is the executive director of Healthcare for All and has written and published extensively on healthcare issues from a consumer's perspective, helping make that organization one of the most notable consumer organizations in the country. He received his master's degree in public administration, I would note, from the Kennedy School of Government, underscore. And I hope will share with us some of the goals of his organization, but also talk with us a little bit about this another step in an incremental approach to covering populations and what his strategies are for achieving the kinds of goals that his organization has put out. Please join me in welcoming Rob.
It's great to be back. On July 24th of this year, the Massachusetts legislature overrode Governor Wells' veto and enacted Chapter 203, legislation that will provide health coverage to nearly all children in Massachusetts. It does this by expanding the Children's Medical Security Plan and Medicaid. 6 days later, 1,500 people, led by Marian Wright Edelman, marched to the State House celebrating the victory. This march was really the culmination of 10 years of organizing around children's health and the health care of the uninsured. How did we do it? We have a conservative governor, we have a conservative Speaker of the House. What's the view from the trenches? And I was in the middle of the trenches, so here are some of the lessons. First, the uninsured parents and uninsured kids are a very important constituency that needs to be organized. Sylvia Pierce called my office in need of health insurance. We run a helpline for people who are actively seeking health insurance who are uninsured. She called, she said she had 4 kids, they were all uninsured. She had been insured until 1992 when her husband was murdered. And she got survivor's benefits but lost her health insurance for her whole family. Sylvia became not just a constituent of Healthcare for All, she became the moral voice of a campaign to provide health insurance for all kids. So when you organize parents, when you organize children, you're getting both that moral voice and a strong constituency. The second lesson in Senator Kennedy's legislation picks up on this. Tobacco tax to improve health access for kids is a winner. People support tobacco taxes. People want access to health care for kids. Combine them, you have a very popular tax for a very popular cause. And third, the fact is most everyone in the United States believes that all children should have health care access. It's the job of progressives and it's a job of people like me to build that coalition. And sometimes we allow differences around other issues to separate us on that. The fact is Bill Von Fossen and Healthcare for All may disagree. Blue Cross and Healthcare for All may disagree on some issues, but we're united around the ideal of healthcare for all kids. It's our job to put aside those differences and build that coalition for healthcare access for kids. I graduated a little over 25 years ago from the undergraduate program at Harvard, and I left college and went to work for the United Farm Workers, and since that time I haven't stopped organizing. You are the troops of the future. You are going to make the change. I urge you, get out and organize. Make Senator Kennedy's bill a reality for all of us. Thank you.
I guess Rob answered our question. I think he supports the bill. Next on our program, we're going to hear from Dr. Theda Skocpol. She is a professor of government and sociology at Harvard University, where she also serves as chair of the Faculty of Arts and Science Committee on Public Service. She received her Bachelor's of Art in 1969 from Michigan State University and her PhD in 1975 from Harvard University. For the past decade, her research has focused on U.S. politics and public policies, as reflected in the recent collection, Social Policy in the United States, Future Possibilities in Historic Perspective. Her Protecting Soldiers and Mothers, The Political Origins of Social Policy in the United States, won 5 scholarly awards. And her newest book, which I think is particularly on point given the challenge we face today, is entitled Boomerang, Clinton's Health Security Effort and the Turn Against Government in U.S. Politics, which has been widely reviewed in the general media. She's also got a current project working on a policy-oriented book on the missing middle, working parents, and the future of U.S. social policy. Hopefully, she will share with us this evening what her sense is of why we failed in the past, why we've been able to come to closure on these issues, and what has prevented those who support it from achieving universal coverage, and hopefully talk a little bit about what the difference could be this time. How do we align the stars that will make a difference in an outcome in terms of a public policy decision? Please join me in welcoming Theda.
Thank you. Well, the 1994 watershed was a shock, I think, both to people who had struggled for years in the United States to realize the ideal, which is still widely supported by the American people, of health care for everyone. It was also a shock to the Democratic Party. And it was an event that separated the men and women from the boys and girls in the Democratic Party. I can't help but point out that after that event, many Democrats decided to switch to the Republican Party, or decided not to run for office again, or decided to become, above it all, critics of the culture in general, because it's easier to sit with the editorial board of the New York Times at lunch than it is to run for office or fight a rearguard action in Congress. Senator Kennedy, however, has stood out as a leader in tough times who has been remarkable for his energy and his tactical savvy in fighting crucial battles in Congress. He has been an inspiration to those who want to revitalize the Democratic Party as the champion of health care for all and of a decent society for all Americans. The Kennedy-Hatch proposal to tax cigarettes to provide money to induce states to expand health insurance coverage is an important example of the kind of adroit leadership that Senator Kennedy has been able to provide in the last several years. It is similar to the Kennedy-Kassebaum measure, which extended insurance portability, and in a way to his struggle on behalf of minimum wage legislation. In each case, he's been able to identify a wedge that I would call an expanding wedge rather than a contracting wedge. He's been able to formulate an issue and a way to meet it that is focused and clear and easy to communicate to a broad public, and he's been able to pull over reasonable Republican support to the cause, while, if you'll forgive the remark, smoking out the opposition on the other side. And I'm actually fairly confident that the Kennedy-Hatch proposal that has been described today has a pretty good chance of making headway in Congress, because it's going to be very embarrassing for opponents to fight it. We should not, we should realize that there will be a fight. Some weeks ago, David Frum published a declaration against this on behalf of conservative Republicans, saying, "Beware health care again." This appeared in the Weekly Standard, and it's recently been repeated in a New York Times op-ed. That's because conservative Republicans understand that popular opinion in the United States, both in the early 90s and now, overwhelmingly supports the ideal of basic health insurance coverage for every American. So when that issue comes onto the agenda, the dynamics of the political and public debate shift against those who want to bash government and reduce its role in providing security for Americans. Let me quickly say, and here I want to speak as a popular progressive Democrat, that while the struggle goes on now to pass the Kennedy-Hatch proposal. I believe it's important for people who care about universal health coverage and for people who want to revitalize the Democratic Party and build a new Democratic majority for the future to set their sights at the same time, not as an alternative, but at the same time on a broader goal. We should be talking about health insurance for all American families and realize that those left out of the system now are mainly working parents and their children. Some may think that this is an unrealistic goal, but recent public opinion polls make it very clear that the American public supports health care for working parents as well as for their children. Right after the 1996 election, Greenberg Research did a survey for the Campaign for America's Future in which fully 73% of the respondents put universal health coverage, this wasn't back in 1992, this is in 1996, universal health coverage at the top or near the top of the list of priorities they want our government to address. And recently, Celinda Lake did a poll for the Children's Partnership. She reports much concern to help children, yet, and here I quote from her report, when people think about health care, they think about it as a family problem, not as a children's problem. They think about unemployed adults and seniors as well as working parents and their children. Popular Democrats, I argue, cannot afford to have a situation in which David Frum and other conservative Republicans argue against expansion of health care for children by saying that that may hurt coverage for near-retired adults or for workers whose employers may drop coverage on them as well as their dependents. Those were the arguments that David Frum just made in the New York Times. We need to answer, fine, if you're concerned about those people, then let's return to the primary goal of ensuring health insurance coverage for everyone. And I'll just close by reminding you of what happens when you ride the airplane. Everybody is used to it these days, but they do that little safety talk where they describe what happens when the masks drop down. I'm usually thinking, boy, if the masks drop down, I'm in trouble. I think I'll start praying at that point. But what they say is if the masks drop down and you're traveling with a child, make sure you put your mask on first and then help your child. Now, I don't think we're going to go about it quite that way. I think we're going to move first on more insurance for children. But we should remember that in the final analysis, what all of America's children really need is healthy parents, as well as the chance to go regularly to the doctor.
Thank you, Theda. I think as she correctly points out, this will be a controversial issue across party lines, I suspect, as well as regionally. Next, we have an opportunity to hear from someone who is going to be at the receiving end of some of this activity, and that is the private sector. Bill Van Fossen is the President and Chief Executive Officer of Blue Cross Blue Shield of Massachusetts. He was appointed president in September of '92, but before locating to Massachusetts, was Senior Vice President of Operational Services at Blue Cross Blue Shield of Michigan, where he served in various operational, marketing, and healthcare capacities over a 20-year period. He holds a bachelor's degree in psychology from Hope College and a master's degree in business administration from Michigan State University. As Senator Kennedy indicated in his initial remarks, the private sector seemed to be a very important component of this effort, and that is the reaching out to them in contracts from the states in order to cover these populations. That idea, that is the involvement of public and private sector in a partnership, is one that has been discussed before, and I think it'll be interesting to hear from him this evening as to what the private sector's response will be, whether these children-only policies are something that the industry, in fact, will be responsive to, and what we're likely to hear from plans like the Blue Cross Blue Shield plan that have a community interest as well as an insurance interest in their history. Please welcome me in joining Bill.
Thank you, Sheila. I'm pleased to be here, and I would want to say right up front without equivocation or qualification that we support certainly the concepts and much of the actual design and detail of I'll call it Kennedy-Hatch as opposed to Hatch-Kennedy, and are very supportive of health insurance for kids or what is commonly known as kids care. My company and I have a history of supporting, I think we have a history of supporting these kinds of notions. Back in 1992, in fact, we set up a foundation here in Massachusetts called the Caring for Children Foundation to provide health insurance on a free basis using contributions from different sources to essentially the same category of children that above the Medicaid level, below about 200%, 185% of poverty guidelines, that same category of kids. In fact, in 1992, we were able to provide a pretty solid core set of benefits for $300 a year. And in 1996, that same cost was up to around $350 a year. If you stop and think, currently a fairly comprehensive HMO package for a family on a monthly basis is about $450 to $500 a year, excuse me, a month. We wish it were $450 to $500 a year. That's a monthly premium. So for less than the monthly premium for a family, you can provide annual coverage under age 19 on a random basis to the youth in our communities. We've been supporting that program. In fact, the program has been, as Rob and I were talking about earlier, really superseded by the legislation passed in the state that becomes effective July 1 that Rob mentioned, the McDonough-Montigny bill, as it's commonly known around here, that extends coverage into children's populations. We also have a history of supporting, I think, healthcare reform legislation both at the local, at the state, and at the federal level. In fact, several years ago, we were early on the bandwagon on Kennedy-Kassebaum, despite the fact that it was, if the senator doesn't mind me saying so, it was not terribly popular within my industry at the front end, but we were smart enough to vote our conscience and not our bottom line and support that bill when Senators Kennedy and Kassebaum proposed it, and are very pleased that it went through. So I would suggest to you a bit based on Sheila's comments, the context of Blue Cross and Blue Shield is not for-profit health insurance. It's community-based health insurance. It's health insurance where we feel profits should be a derivative of serving communities and trying to improve not only financial access, but quality access to quality health care. So the mission, the purpose, the kind of persona of the company that I represent is very consistent with that Senator Kennedy is calling for from the private sector, and we're pleased to support the initiative. And I would just say I look forward to discussion after the introductory speeches. Thank you.
Thank you. And finally, our last panelist is our provider representative, which is a nurse. It's always a treat to have somebody come and talk about the delivery side. Dr. Barry Zuckerman is a professor of pediatrics and public health and the Associate Dean of Clinical Affairs at Boston University School of Medicine and Chief of Pediatrics and Medical Director at the Boston Medical Center. He, in fact, individually has developed and implemented special programs for children in Boston, some of which, in fact, are being tracked and followed nationally. These programs emphasize prevention, go beyond the traditional medical care in terms of a broader model of services that are necessary to help children. The Reach Out and Read program, which is being replicated nationally, promotes literacy for young children in primary care settings. The Pediatric Pathways to Success program is a primary care program that expands access to needed basic services and child development and all-important parenting skills. He is the author of more than 120 scientific publications, emphasizing the relationship and impact of biological, social, health services, and psychological factors on children's health and development. He is the editor of 4 books. He has played a significant role in the development of the American Academy of Pediatrics Child Health Supervision Guidelines, and is otherwise kind of a nice guy. Please welcome me in joining Dr. Zuckerman.
Thank you very much. Before I start, I want to acknowledge again the special contribution that the Project Health people have made. Rebecca Oney particularly, I remember when she first approached me with this idea and we chatted, and that happens a fair amount. People come with ideas and you give them a little support and advice, and 9 times out of 10, that's the last you ever heard of it. About 8 months, I told her to speak to some people and we talked about some ideas. 8 months later, I heard this program is up and running, and I think that speaks towards Rebecca's leadership, and it also speaks towards the commitment of the students. And I'm very optimistic that with the commitment I see with you all, and it goes beyond, it addresses all the things we need to. It's frontline work, and it's also thinking and dealing with policy issues. And I think while I'm optimistic about where we're going, people are now looking about what's the right thing to do, just like Bill Van Fossen said about voting your conscience. And I think when that comes up, everything aside, maybe we're at a point in history where people are now looking at that. I want to leap ahead. I want to make an assumption that not only the Kennedy-Hatch bill will pass, but in terms of the senator's long-held belief that will be universal health insurance for everyone, and maybe it'll be 5 years or 10 years, and this will be the first incremental step. Think about what, as providers, what should the system look like so we can best help children's care. And I'm predicating my remarks on what I think some scientific advances are going to mean to us. It seems like every year now we have a new vaccine coming on board that's really reduced significantly specific childhood problems. One form of meningitis we hardly ever see anymore. The hepatitis vaccine is out. There's going to be some new vaccines for very special respiratory and GI diseases. And with these new advances, what are going to be the proportional causes of children's problems? Well, I believe they're going to be related, as Theda said, we didn't get this together, on parents' health, particularly their mother's health. And I also think that what you're going to see is the problems are primarily going to be around children's development, their ability to learn in school, and not only their learning in school, but the cycle that that's going to have towards their health. Everything is interrelated. So if you accept that we're going to see this changing pattern of morbidity, what should our system look like for caring for children? I think we need to go, and we will go beyond a pediatric practice, thinking of a system of care for children, and specifically, I think what we're going to see and what we need to develop is 2 factors. One, promoting children's development as part of this system of care, particularly young children who aren't yet in school, and it needs to be combined with early Head Start, which the Senator has been a strong component with, and health care and family support and child care. So we have a cocoon for parents that will give them the information and the support to promote their children. In pediatrics, what I'd hope to see happen, it's based on our Reach Out and Read program, where at every pediatric visit, the doctor gives a parent a book starting at 6 months of age for every visit up to 5 years. We did an evaluation of the program showing that parents who participated were 4 times more likely to read to their children compared to those who did not, and parents on welfare 8 times more likely. I mean, that's a big bang. We get the books for about $2 a book. There are 10 well-child visits between age 6 months and 5 years. That's $20 to $25. What can you buy for that could be more special than children starting school with 10 books in their home? And that's one thing I think all of us with this new information about children in each profession, in each area, have to say, how do we adapt, how do we change, how do we meet the needs of children? Obviously, promoting literacy is not something traditionally pediatricians do, but why not? We're talking about children. We're not talking separating their health from their development, from their social well-being. We're talking about whole children. And again, in my own way, try to follow the Senator who, for children, promotes legislation for families, for child health, for child development, for learning, and I think, that's a model that I try and keep up with. I think the second piece is something, again, that Theda alluded to, and that's parents' health, specifically women's health. And I want to talk about 3 or 4 aspects of that. Reproductive health. The planning of pregnancy is particularly important. Over half of pregnancies in our country are not planned for when they're wanted or missed time. That, if the interval is too short, can be associated with low birth weight. It also, if it's not only not planned, then parents psychologically may not be ready to parent. And there are a number of other concerns around the planning and timing of pregnancy from a family's point of view. So reproductive health is important, and certainly the issue of safe sex falls as that. Health behaviors of parents, cigarette smoking being an important one. These are known to cause ear infections, respiratory infections, and even behavior problems in mothers. Now, by the way, I want to be clear, when I'm saying these health problems, I'm not talking about during pregnancy. That small time during pregnancy, it really doesn't have an impact. We're talking about women's health for its own sake, for the woman, and for the sake of their child. It's a traditional twofer, if you will. So we have reproductive health, we have health behaviors, we have mental health. Depression is common, and it's a problem not only for the women, but we see problems for children in terms of behavior problems, learning problems, injuries, and a number of other things. And also violence. I don't need to talk about the issues of domestic violence, and again, the woman being the primary victim, but there are always children who are watching that frequently. What impact does that have on them? So what I see for the future is pediatric care has to link itself to women's health. And it's a little bit different than really family health in my own point of view, because we're talking about health promotion for women particularly, and I don't want to leave out the fathers, but in a lot of key ways, it's the women's health that are very important. And I think we're going to need to develop systems, and in that system promote children's development. Literacy is only one way, and somehow ensure access to care for primary women's health care. And I believe that access should go beyond just a pediatric setting, but include child care settings and all, because we know 40% of women raising children do not have access and are not visiting their physicians, and that's, again, important for them and for us. So I think the future is, when we have the financial access, we have to develop a system that's going to be much more focused on what I believe the future needs of children are. Thank you.
Thank you very much. I ask you now to come to the microphones, if you would, if you have questions, and in addressing us, if you wouldn't mind identifying yourself, giving us your name and where you're from, and who on the panel you would like to have respond to your question. And while you're doing that, let me take the opportunity as the moderator to ask the first question. And I wonder if Senator Kennedy might share with us, I know he talked a little bit about this yesterday with Senator Hatch on Meet the Press, about your sense of your chances in the Senate, but also the kind of work that's going on the House side, whether there's going to be comparable work, and also the response you're hearing from the governors, who are going to be a critical participant in this because it is a voluntary program.
Let me first of all say that I'm very hopeful that with regards to the Senate action. Senator Hatch will announce several Republicans tomorrow, and I think, having talked to a number of Republicans myself, I think we'll move very quickly into a majority position in the Senate. I think the large majority of the Democratic caucus are supporting it today, and I believe they all will by the time we get to the floor. We're far ahead of where we were when we passed the Kassenbaum-Kennedy bill that dealt with the pre-existing conditions, and we're far ahead of where we were when we had the minimum wage debate and discussion. So in that sense, I'm very, very hopeful. I believe that the President will support this program. We're putting it in. It's somewhat different than the earlier bill, which Senator Kerry and I supported. Has some difference, but I believe that the President will support it. The President has supported tobacco tax and the health security bill previously, and the President has probably more than any other president been willing to take on the tobacco industry. And if you look over the recommendations that he has made with regard to children's health, which expands children's health with regard to the Medicare, also provides a component for looking after children of working families in between jobs. They'll pick up about 700,000 children there. And the third component provided some $700 million for states to move ahead and to deal with children's programs. If we're able to take and then plus the pooling arrangements, which I had not mentioned, which is included as part of this bill, which will permit those children that are not eligible for the subsidies to still join in a state pool. Effectively, if you add those elements together, you're going to provide coverage not only for the children that are eligible, for those full subsidies below the 185% of poverty, but you'll also provide the option for children virtually of higher incomes, particularly in higher incomes when they have a number of children, to be able to participate in a pool. So if we're able to get all of those together, we're really talking about a major effort, and I think all of those fit closely together and match very closely with the President's bill. Finally, let me just say Senator Hatch has talked to Republicans. I've talked to Congressman Porter, Congressman Thomas, both very involved in Republican, and Congresswoman Rokema, as well as other Republicans. There's a great deal of interest in the proposal. Senator Hatch wanted to have the opportunity to talk with them in greater detail, but he has indicated to me that there's, in the initial conversations, there's positive responses. So I'm very hopeful both in terms of the ultimate outcome, and I'm very hopeful in terms of the bipartisan nature of the coalition that'll eventually support this on the floor of the Senate and the House of Representatives.
Let me start on the right, sort of instinctive. Identify yourself, please.
Yes, hi, I'm Dr. Walter Harris. I'm Chief of Pediatrics up at Rustuccia Children's Hospital, and I practice in the city of Lynn, which about 40% of my practice is Medicaid and uninsured. And several years ago, I testified on behalf of the Medical Society and the Academy of Pediatrics to have funding for a second booster of measles, mumps, and measles vaccine. This was one of the few states around the country where there weren't hundreds of children who were infected and in several cities died from measles, mumps, and measles because people couldn't, from measles, because people couldn't afford to get the measles vaccine. In my practice, I've seen already starting decreasing numbers of kids who are no longer smoking and who are talking about stopping to smoke. So I would just encourage you to forge on just the way you're doing. And Blue Cross has been supportive of this kind of initiative. Thank you.
Thanks. On my left.
Hi, my name is Lisa B., and I'm a graduate student here at Harvard University, the Extension School, and my question is targeted to Senator Kennedy. I was wondering, I went blind as a teenager in the late 70s, and unfortunately, after I went blind, the medical profession did not know what to do with me. They had no idea where to direct me in the right direction. So I was wondering, is there any money that is allocated for children with disabilities so that the medical profession could maybe become more sensitive, you know, have some sensitivity training towards people with disabilities?
That's a good question. The fair question is, I mentioned to you earlier that we're going to develop these pools. I strongly favor community rating. So we're going to have eligibility for all students. We were not able to get that as a principle, as one of the compromises. I feel very strongly in terms of community rating, which gives the assurance that all would be able to, those with disabilities, be able to come into the pool. I think that that has to be a fundamental tenet. We were unable to get that at this time. But we did make a provision in the legislation in terms of those with disabilities, which will permit them to get into the pool at a somewhat different rate. And we'll be addressing that, trying to, as we move on through the hearing process, to see how we can best deal with this. If you move towards a community rating, we get very, very, I'd ask Mr. Van Essen about it. He might talk. I commend him for supporting the basic concept, but I think he might understand the nature of the additional political problems that we're facing. This is a tough political issue. I mean, we either make some progress in these areas, but we're not going to make as much progress as we should in terms of the coverage of all those with disabilities, although we put them on a preferred position in terms of availability and accessibility in purchasing this, and it will be at a more reduced rate than it exists. Once you make available for all poor children under 185, you pick up a number of disabled in any event children. So we get, without the community rating, we probably get 65 or 70%. I'd like to get 100, but that isn't what we're about in this business, unfortunately. I think you make a good case. We clearly don't do as much as we could. I hope you'll, we're going to be dealing with other issues affecting the disabled, and that is the IDA program. I hope we can get that reauthorized, which deals with disabled in schools. It's a very hot-button issue that we haven't got clear consensus on now, which very much affects about children and education, and opening up education to some 5.5 million disabled that go to schools. That's very, very important. And we're going to very much concerned about the changes in the welfare system that dropped some 250,000 disabled, which I opposed. And we're going to make an effort to try and address some of that in the budget debate. So we, on the issues affecting disabled, there's a number of different areas where we need all the help and the support on it, but I appreciate your mentioning this, and we want you to know that I'll be glad to keep you abreast about how this whole proposal, as it affects disabled, if you would give me your address afterwards as we go forward in the debate. Thank you. Thank you.
Bill, I wonder if you might want to comment, and also I wonder if Barry might want to comment. Bill, in terms of the community rating issue, as Senator Kennedy indicates will be, and was even in Kennedy-Casaubon, one of the most difficult issues to confront. And then Barry, I wonder if you might comment on the issue of benefits. As I understand it, Senator Hatch and Kennedy's bill deals with the Medicaid program and its benefits, and whether as we look at those needs in the disabled community, whether the service distribution is the right one as we know it today.
Let me try to run through this quickly. Up until the end of the 60s or so, the health insurance system was operated on the basis of community rating, and that was essentially that within certain segments everybody was in the same pool. And in the 70s we started to break that down. The industry moved away from community rating to experience rating, and gradually moving to smaller and smaller insurance pools. Insurance works best when you have big pools and when people in the pools are treated commonly. So I agree with the senator that community rating is the way to go. It's the preferable approach. It's the more inclusive approach. It treats everybody the same. And I think when we get beyond, as I said earlier, we need to build a consensus around momentum for the bill. When we get past that kind of in concept and get into the plumbing and wiring work, limitations on medical underwriting and restrictions on experience rating within this bill will be very important. The more community rating we can get, the fewer opportunities to medically underwrite the more we can avoid medical underwriting, the better off we'll be.
And I assume that the biggest opponents of that will be some of the large employers who, in fact, benefit if they are a certain work group in terms of lower rates because it's experience rated.
Not only large employers, but a lot of my counterparts in the insurance industry who have made lots of money on the ability to select out of
healthy people.
The community healthy people.
Barry, did you want to comment at all on the benefits package?
I would. I'd just actually like to ask Bill one question. When you're talking about community rating, does that negate the need for risk adjustment because of a large pool? Or would you still need to risk adjust within that larger pool?
The ultimate of community rating requires no risk adjuster because everybody's in the same pool, and it's when you start breaking down the pool and moving to second tier, third tier kind of.
Because the classic adjustments are age and sex, and
right.
I mean, those are the ones that are most traditional in place.
Yeah, my concern would be until you get to that large enough pool that there'll be, with certain capitated systems, there'll be a negative incentive to provide all the services, particularly for people who could be high users because they have a disability. And how we think about scope of services, and some people, what's worth reminding people that the Medicaid, while there's over the years, less so now, the implementation has been an issue. It is one of the best benefit packages we have, and children do benefit from it. And I think that's going to be a tension between, appropriately allocating resources and make sure children, let alone adults who have disabilities, get what they need, and they're not incentives to keep them from getting that. And I think that's a tension, and that's going to have to be worked out at multiple different levels. But as you did explain and just confirm to me, the large community rating should negate that. But until we get there, there's going to be some difficulty.
Thank you. Yes. Yes.
Hi, my name is Ronald Goldman. I'm a psychologist and executive director of the Circumcision Resource Center in Boston. I want to call attention to an issue that I think is trivialized and overlooked, and that is the circumcision of male infants in this country. Recent studies have shown that this causes overwhelming pain and trauma, disruption of infant-mother bonding, and other detrimental effects. And we get calls at the office from parents who are surprised to discover this information after they've given consent. I asked the panelists what they might recommend to better educate not only parents but doctors about the adverse effects of this practice, and particularly regarding the question of insurance. Certainly if parents choose this and it's covered by insurance, it's no money out of their pocket. Some insurance companies are choosing not to cover it because there's no proven medical benefit.
Dr. Zimmerman, did you want to
Yeah,
throw it to you? I'm not going to answer it.
I think I would take exception to some of the claims. I'm aware of the literature, and to some extent what you say is true. I think the larger issue is providing the consumers with accurate information and the mechanisms we do that. Actually, I have a particular concern with a variety of the computer systems, internet, all the information that's getting on there. How is a consumer going to deal with and make judgments about information in terms of its accuracy? So I think we can debate that, but I think the larger issue is ensuring that accurate information is disseminated so all people can make good choices about what they need and what they want.
Bill, did you want to comment just briefly on how decisions are made on coverage in terms of whether it's in response to physicians requesting or consumers in terms of their purchasing?
Yeah, let me start first with consumers. The opportunity, we have to, the industry at large, and in fact principles of insurance require that you limit the opportunity for consumers to pick and choose procedures that they want covered in their policy and the time during which they want them covered, because they're essentially then designing their own indemnification policy against what they anticipate their experience to be. So in keeping with the notion of community rating, there also needs to be a community standard around coverage. So we need to avoid consumers really getting into a pick and choose, I'll have one of these, two of those, but none of these kind of situation. With regard to physicians, we rely upon the medical community. Not only here in the state, in the Commonwealth of Massachusetts, but nationally, to essentially make decisions about the medical efficacy of different treatments, those emerging new treatments. So you don't find a lot of health insurance industry decisions that are made contrary to the accepted treatments within the medical profession.
Thanks, Bill. Yes.
Yes, my name is Dr. David Rosenthal, President-elect of the National American Cancer Society and Director of Harvard University Health Services. And needless to say, the National American Cancer Society is going to strongly support and advocate for the Kennedy-Hatch bill. We will do anything to increase the lack of availability of cigarettes and tobacco to children. Pediatrics has always been the discipline, the model discipline in my mind, and personally, and I think that it sets a sort of standard of, a regimented standard of frequent care, frequent immunizations, and frequent follow-up. Somewhere along the way we lose that as we get older. But there was some concern raised, I think, in the Globe over the weekend about the fact that even though we have increased the tax on tobacco here in the Massachusetts, and we have made this available to the health care of children, the process of getting children into health care is still a major issue. And I'd be interested in the panel's response to how do we get the children who are uninsured into the health care system?
Rob, do you want to?
Well, I think, first of all, we have to understand we have a Republican governor who is implementing a law that passed only over his veto, so his administration is not particularly interested in implementing this law. I think across the country, though, we've seen problems with getting kids into Medicaid in particular. And I think there's a lot of studies being done now that really look at what's the best way of getting parents to sign up their children for Medicaid. You know, the fact of the matter is in this state, which I think is probably better than most other states, it's extremely difficult for a parent to sign up their kid for most health insurance programs. If you are denied Medicaid coverage, in general, you're not told about the Children's Medical Security Plan, you're not told about the Common Health Program, you're not told about the free care pool. So, you know, we are trying to address the state bureaucracies and try to get them work together, make them consumer and parent friendly. So, you know, it's going to be a struggle. The way we look at it is passage of legislation is about 1/4 of the way. Implementation takes another 3/4.
Well, and our experience with immunizations in particular, I suspect, shows us that half the battle is getting the mother to bring the child and educating the parent about the need for those visits. Theda?
Yeah, and I think we have to realize that we're in a political climate now where budget cutting is the norm, and there's a great deal of pressure in that direction, so that any kind of legislation that passes now to increase the right of access is going to be competing with a whole series of pressures on state governments and on providers to cut back access for the same children or for comparable families. I think that's part of the reason why ultimately it's going to be important to think about this as a family issue and as an issue of connecting families to resources in a post-welfare environment. The demise of welfare as we knew it is creating a whole series of blows that have not yet worked their way through the system in terms of discouraging access to all kinds of services as well as to welfare benefits. But it also opens up a vista of thinking about this as a situation of connecting working families to the kinds of supports that they need for themselves and their children.
Barry?
It's a good opener. Some of you may remember the Stand for Children last year in Washington. There will be another one June 1st this year, but it all involve local activity, and it's labeled Stand for Children's Health. What the Boston Stand group is going to do is a citywide and even Eastern Massachusetts effort to sign up all uninsured children. It's going to happen in a variety of ways. It's a large group of organizations. Healthcare for All has been part of it. The health centers have been part of it. The churches, the community centers, and the schools. There'll be a lot of visibility and notification in many different languages to families because, again, I think it's going to take that broad-based effort to bring it the attention of people as opposed to the Department of Public Health brochure that comes out and sits in WIC's offices and maybe gets sent to practitioners. You know, the churches have said they will speak about it, you know, on their sermons that day. And to top it off, and I have to give credit to Bill Harris, because if I don't, he'll never give me another piece of advice. We're gonna have what we call a bounty. Any family organization that brings in an uninsured family gets signed up, we're gonna give them 10 books for either their organization or their family. I think when it has that kind of visibility and a whole community is involved, we stand the best chance of doing it. And I think we're going to be looking for volunteers to help us in many different ways, so that's my plug.
Yes.
Hi, my name's Errol Katz. I'm an MPP1 from Australia, where we're fortunate to have universal health insurance. My question is to Senator Kennedy. It relates, I guess, to the strategy of incrementalism. I know no one has the energy for a full change of the healthcare system, but given that children are relatively cheap in terms of health care and they certainly do tug at the heartstrings, how concerned are you that an incremental change to bring healthcare to children will in fact detract from what I know to be your larger goal of bringing universal healthcare to all Americans?
Well, let me say I wish it was the nose under the tent or the foot in the door, as the opponents will say it is, as I mention this to my colleague and friend Senator Hatch and say this is starting off on the slippery slidey slope towards comprehensive health. I wish it were, but it isn't. And I think it's a reasonable question about, you know, how you develop the kind of combination of either coverage or other elements in legislation to develop to have a compelling force that's going to pass. I had thought, quite frankly, when the President had put his bill in that we should have included the longer term for the elderly. I thought rather than slowing the process down, you would have gained an additional kind of component, because you would have gotten a lot of working families that already had coverage that were rather indifferent to the fact they were paying for coverage of uninsured, but that they are looking down the road in terms of their parents, so that they might have taken additional kind of an interest in it, and it might have had additional kind of a political process. So, you know, the point that you make about how it eventually is presented in terms of its how it'll be accepted and debated and eventually passed, you know, is a reasonable question to pass. I don't think we can tolerate a day more going by with 10 million kids not having it. I think that that's for us to, the other side of the question would be, well, shouldn't we hold back and wait, let this force build up, and then use it as an impetus to pass a more comprehensive way? I think I wouldn't accept that. I think most people wouldn't. We ought to deal with what we can get now. I think we ought to also follow on. I think there are other health issues that I'll just take 30 seconds mentioning. I think we ought to try and get a Consumer's Bill of Rights in terms of protection for insurance and for HMOs. I think that's important, so we deal with some of these situations of drive-by mastectomies and other kinds of issues that have come to the fore. Not as much in Massachusetts, let me say, but nonetheless out there and has to be addressed. And I think we have to deal with some privacy issues in terms of HMOs that are real issues. So there are a number of factors and forces which I think can, at a time, quite frankly, that we're going to have to target individual members that have some interest in this to try and build the coalition, given the deck of cards we have in terms of control of House and Senate. Been very delicate tonight about how we expressing our views about this under our new mood.
I appreciate that.
But I want to keep Sheila. You never know when I might be able to get Sheila to talk to Bob Dole about this bill. But I think we've got some very important other issues that are coming along. But I would hope that down the line we would come back. I'm strongly committed. I've been on 12 different bills. I don't care how we do it, as long as we get it done eventually. So.
Yes.
My name's Joe Lewin. I'm a student at the Kennedy School. Senator Kennedy, there's one thing about your bill that concerns me quite a bit, and that's that it's going to make it easier for employers to drop dependent coverage if they know that the government's out there paying for it, and that as a lot of kids might lose coverage from their parents' employer insurance, we're going to have more kids coming into the system, and you don't have enough revenues in your bill to cover them when they come in. And the end result might be that a lot of children, principally middle-class children, may end up worse off. What can you say to alleviate my concerns here?
Well, first of all, I think it's a legitimate question. We have tried to build in protection so that that would not be the case. For example, an employer can't employ 50 people and drop 10 because they've got the children, the ones with the children. They have to drop everybody. All of their employees. They can't just drop the children, they have to drop the others as well. We have those measures built into the bill, but I think whether those are going to be successful or not, I think as we can find out as we go along. In the states, we have 31 states that have different formulations of this. 17 have sort of important ones, maybe 10 of them have very significant ones. It hasn't been a problem in those states. There's some is somewhat of a problem, but not a serious one. We've been monitoring that very, very closely, and we've tried to build in protections. We've reviewed the various state proposals that have addressed this issue. There have been a number of different ways that they have formulated, and we're working to try and find out which ones have been the best on it. So we're going to build in the protections. I think there are different suggestions about how those have been built in, and in the states that have done this, it hasn't been a significant issue or problem, although I think it's one we have to keep our eye on. And I think we have to expect that there'll be some, but I think we'll be able to deal with that.
Yes.
My name is Brian Rosenthal. I'm an undergraduate here at Harvard. My question, I guess, is targeted for especially Senator Kennedy and Mr. Von Fossen. Children have unique psychiatric needs as people growing up and maturing. What place do you see mental health as in a standard benefit package in any type of comprehensive program?
Well, we have under the Medicaid their mental health provisions, and it's a reasonable program. you can have a more expansive program, but that would be, we're basically modeling our program after the Medicaid program. There are mental health provisions. Let me just say that I think we have seen a dramatic change. I think Sheila Burke would agree to the nature of the debate that we had on the floor last year with regard to mental health and where we were probably 4 or 5 years ago. There was, last year we did make a modest change. There was a significant change in just in the total vote about whether we are going to treat mental health the same as other health care. And then eventually we passed a modest provision in terms of treating mental health as the same as other health care expenses. What is happening is I think that most of us understand that there's enormous pressures, particularly in HMOs, on health care. And what I mentioned earlier, one of the very interesting phenomenon is that with the pressure on mental health, particularly on mental health in HMOs, psychologists and psychiatrists, you probably have some here, by and large have to identify a more serious condition for the patient in order for the patient to get the kind of treatment that they think they need. And that goes in, at least this is a lot of information I've got from a number of psychiatrists and psychologists who I respect. And that goes in their medical records, and the medical records without these right to privacies are out there, which are enormously accessible and available. So you have people in their records being put out there that are going to be able to be drawn down from various kinds of groups that are able to tap in, which I think compromises in a very significant way people's privacy issues. So we have a number of different issues involving the mental health. I think the direction that we're going on in terms of HMOs is a very important one. I do believe what we have there with regard to children is a reasonable one where, you know, it's like anything else, we're going to have to watch it very, very carefully. And I agree with the earlier comments, and that is the kind of pressure that children have in urban areas and schools in terms of mental needs is out of sight. And we as a society are not sort of dealing with it nearly as effectively enough. And I hope that we can do better.
As Senator Kennedy said, Pete Domenici in particular, I know worked with Senator Kennedy and has a very personal interest in the issue of mental health coverage and parity. And it has changed. The debate in 10, 15 years, the last 10 years, has changed dramatically in terms of people's receptivity to that in the broader context of health services. Senator Kennedy, unfortunately, has to leave us to catch a flight. We're going to go on for a few more minutes, but please join me in thanking him for coming this evening. We're going to go for just another 5 minutes, so if everyone will, and try and answer a couple of these questions, if you'll stay with us for just a few more moments. Yes, sir.
My name is Joel Alpert. I'm a pediatrician who preceded Barry Zuckerman at Boston Medical Center in some, but not all of his jobs. And in a short few weeks, I may or may not be president of the American Academy of Pediatrics, depending on the outcome of an election, the ballots which are now in the mail. What's different today? And I think, Professor Burke, my question really is directed as much at you as it is with everyone here. Senator Kennedy, I've been involved in some things in years past. We've labored a long time. We have not succeeded. The words of rhetoric have outstripped our actions. To the students in the room, the torch that we're passing on to you presently is not a bright one, because the circumstance of children has deteriorated, and deteriorated badly in this country, especially when compared with other industrialized nations. What's different now that should lead us to some optimism, and what can we do to work together to form those alliances that are necessary to make the political event occur, which is admittedly a compromise, but an important one, to ensure all children in this country?
Let me turn to the panel first. Theda, did you want to touch on that a little bit, given your work and what didn't work last time?
Well, there is a coming together of people who are civically engaged across party lines around the issue of doing something on children's health, and that's hopeful. I think the issue has also come to the fore right now because it's inexpensive. And I guess that's good news in a way, because we're in a new budget climate where people are looking, including active citizens, but also elected politicians in both parties are looking for something that they can do to address issues of concern to the general public, but especially to women voters, I believe, without spending a lot of public money. But I would be, I'm not entirely optimistic about where this is going to go. I'm not sure that this legislation is going to pass. And even if it does, there are serious issues of implementation of the kind that have been discussed on this panel. And there was a very interesting article in the National Journal last week by Marilyn Serafini arguing that even if this legislation passes, the net result by the time the budget pressures and the transformations in medical care through managed care work their way through, the net result may be fewer children covered than before. In other words, that this may be a stopgap effort rather than one that is going to push forward toward universal coverage even for children. I didn't want to mention those kinds of depressing things early in the panel, but I think that one should be only guardedly optimistic about what's going on here if the political balance of power and if the budget pressures on states and localities as well as the federal government remain as they are into the foreseeable future. In the final analysis, we have to say the word tax. We have to talk about ways of getting more revenues into the system. And I don't think we'll be able to get them all out of the cigarette companies.
Rob, did you want to comment?
I think I've noticed that because we've moved to a more corporatized system and that healthcare is becoming more of a business, that you find more of the people within the healthcare system really understanding that you really can't have a competitive healthcare system without expanding entitlement. So I think one of the trends we saw in Massachusetts is much broader support across the industry. I mean, the insurance industry, the business community, all supported expanding health access for children in Massachusetts. I think to some extent, people realized as we move to a more strictly competitive healthcare system, the safety net gets squeezed, and that we need to have more entitlement. That's my hope. I share Thea's concern, though.
Bill?
I think it's very helpful that the composite rate of increase in healthcare costs that was 2 times, 3 times rate of inflation up until 4 or 5 years ago has moderated substantially, and that there is a willingness to talk about incremental reform rather than this kind of overwhelming composite concern, especially from employers and the business community about what are you going to do to moderate my 15% increases a year.
Barry?
Well, I'll take a shot at it, even though it's out of my realm. I remain optimistic because otherwise it would be hard for me to get up and go to work where I work every day and think that something won't change positively. Whether it happens this year or not, I feel that whether it's the election in 2 years or in 4 years, people in Congress, when they go back home, are going to have to point to something positive that they do that people will like. And I think this is certainly one piece, and there could be something else. And I think there's going to be pressure from the public for them to hear, what did you do? And besides a lot of things that they will do, something that people can feel good about. I think secondly, while I'd like to see more constituents on the bill, and someone alluded to the elderly, I think the tobacco tax is very interesting. And granted, it's going to create significant political conflict around these key states that are very important, but it's an interesting time to do it, and in some ways I believe it will be the bellwether to see what we're doing on whether politics are going to now turn, whether that traditional constituency can hold its own. But I think combining people who are interested in children's health, people who are concerned about the adverse effects of tobacco is going to be a very interesting dynamic to watch over the next year.
Well, I'm a moderate Republican, so I have to be optimistic as a general matter. I think that Barry raises some very interesting points. Actually, each of the panelists have in terms of the potential for success. And the 2 interesting points that he raises, one is the odd sort of timing in terms of the desire of this Congress to go home in a couple of years, having proven they could do something. They began talking about bipartisanship for a reason, and the reason was they didn't want to appear to be a do-nothing Congress. So the potential is there for them to try and come to closure, just as they did in the waning days of the last Congress on a series of things, including the Kassebaum-Kennedy bill, that there was great pressure to actually come to closure on an issue and break down this sort of partisan bickering. So that has the potential of making things move. The other is this odd issue of tobacco. And as I indicated in my opening remarks, these issues will cross party lines and regional lines. That there will be battles fought that are not Democrat-Republican battles, but are Southern tobacco state battles. And it will be very interesting to see whether the increasing pressure on the broader issue of tobacco and taxes plays out at this time around, and what that pressure point is like in terms of those southern states and the southern state strategy as they look towards the attempt on either the Republican side to increase to 60 in the Senate or the Democratic side to try and move back in the other direction in the next go-round in terms of the elections. There are a lot of other things that would potentially be stars in alignment. One is that it is kids. And so it is a popular group. It's not, they separate it from welfare moms and sort of those other negatives that people talk about. And it's also relatively less costly than a lot of other issues, which has some potential in terms of an opportunity. But it also involves people across the party lines, people like Olympia Snowe and Marge Rockema, as Senator suggested, and Nancy Johnson and others. Women in both the House and Senate across party lines who've tried to get issues relating to women and children at the front of the agenda. So all of those things may move it towards the front of the line in terms of possibilities. But Theta raises some very interesting issues and important ones as well. And that is the issue of what happens at the end of the day in the deficit reduction talks and how that's driving many of these issues, as it has really for the last 15 years in terms of public policy and healthcare policy as it's driven by budget debates. But also how it gets lined up in the alignment in terms of the other kinds of issues they have to confront. So I am cautiously optimistic, but conscious of sort of all of the issues that tend to bring things down at the last minute, including implementation issues, and the same questions we're facing now with Kassebaum-Kennedy, and trying to get it put together and in alignment in terms of the kinds of things we wanted to achieve. So we're looking at a mixed bag. Unfortunately, we are, in fact, at the end of our time and having gone over some. Let me thank all of you for your attention and your participation, and the group again, the students. Thank you. Oh, I'm sorry. I wish I had as well. Oh, well, there'll be other opportunities.